Welcome. I want to thank you for your time and your willingness to expand your abilities. Our time together, although limited, potentially can be most important. When one evaluates the current position of clinical endodontics as a healing art, one is struck by the vast differences in which endodontics is understood and practiced from dentist to dentist. Yet, rational methods of treatment are available, precise techniques have been perfected, and technologically driven advances are becoming routine. Verifiable success rates approaching 100% are attainable. The information that I'm going to present will represent the best that has endured from the past and the most recent advances in clinical endodontics. I trust our time together will phenomenally impact your success and personal satisfaction. Let's get started. Over the life of a patient, the dental pulp is vulnerable to injury because of a limited blood supply, it is encased in unyielding dentinal walls, and has terminal circulation. Regrettably, many pulps become compromised because of the invasion of bacteria through the enamel and into tubular dentin. Ideally, if a carious lesion is eliminated early, a simple restoration is the treatment of choice. However, for many patients, progressive and more extensive dental procedures are commonly performed to address recurrent decay, restorative failures, certain periodontal lesions, or specific types of traumatic episodes. It is wise to completely understand and fully appreciate that repeated dental procedures threatens the health of the pulp. In general, pulpal degeneration and disease flow move in a coronal to apical direction. It is fundamental to associate radiographic lesions of endodontic origin as arising secondary to pulpal breakdown and as forming adjacent to the portals of exit. This phenomenon originates in a space exhibiting infinite anatomical configurations and intricacies along its length. Root canal systems commonly contain branches that communicate with the attachment apparatus furcally, laterally, and often terminate apically into multiple portals of exit. Consequently, any opening from the root canal system to the periodontal ligament space should be thought of as a portal of exit through which potential endodontic breakdown products may pass. In this case, we have a gutta-percha point tracing a fistulous tract to a lateral root lesion. This video will emphasize the importance of diagnosis, complete access, shaping the canal, such that our irrigants can penetrate into all aspects of the root canal system, and packing in 3 dimensions. The follow-up film shows complete healing. Let's look at some root canal systems. Every dentist could pack in 3 dimensions if they had the shape. The desired shape produces a 3-dimensionally cleaned root canal system that every dentist can pack effectively. A fundamental law of physics states only one mass can occupy the same space at the same time. Shaping serves to remove all contents from the root canal space and creates the opening for 3-dimensional obturation. Shaping facilitates packing by removing restrictive dentin, which allows instruments to work deep, unrestricted by dentinal walls, and to subsequently move thermosoftened gutta-percha and sealer into all aspects of the root canal system. In summary, the shape is critical, not only for effective cleaning, but for 3-dimensional obturation. Consistently producing the shape is one of the strategic cornerstones in the foundation of endodontic success. Although the excitement of a well-packed case is deserved, scientific evidence should support our enthusiasm. Ongoing debate surrounds the question, can a root canal system be totally cleaned? In this inset, you can see that a shaped canal readily receives irrigant. Irrigants can then penetrate and circulate into all aspects of the root canal system and liberate the canal from organic debris. In this cleared section analysis, you can see how irrigants can penetrate off the primary canal and even into very, very fine ramifications in this loop. This lateral incisor was treated in vivo and then extracted. When we look at the SEM, we can see that both lateral canals have been cleaned of debris. Further, a higher magnification view shows that even the dentinal tubules are open and patent. This high magnification reinforces the concept that irrigants can penetrate deep into the tubules and eliminate organic materials. So we have seen evidence to support that shaping facilitates cleaning. Shaping also facilitates packing. Evidence supports a root canal system can be cleaned when we have produced enough shape to fit a fully tapered, non-standardized, fine medium or medium master cone. The idea is to thermal soften the master cone, and utilizing a pre-fit plugger, we can carry a wave of thermal softened gutta percha into all aspects of the root canal system. You can see how hydraulic the pack is in this plastic model. In this clinical photograph, you can see in the buccal canal of the bicuspid, there's gutta percha in the lateral wall, providing powerful evidence of our ability to pack in 3 dimensions. It's reassuring to look at the postoperative film and see a compact pack over all aspects of the anatomy. In this mandibular molar, the clinical crown disrupted and came off during the access preparation. The tooth was subsequently banded to create a reservoir of irrigation. The canals were cleaned, shaped, and packed in 3 dimensions, and the postoperative film shows surplus after filling. As a teaching case, to demonstrate that surplus after filling is irrelevant to the outcome, a buccal flap was reflected, and we can see a massifurcal blowout and a distal infrabony pocket. 2 years later, the patient was reappointed for recall, a simple surgical procedure was again performed, and you can see the inevitability of the bone to rise to the surface after careful cleaning, shaping, and packing. A postoperative film demonstrates complete osseous repair. Evidence-based endodontics provides compelling evidence of the completeness of the pack. In this cleared section analysis, looking at the proximal view of the mesial root of a mandibular molar, we can see a fin, webbing between merging systems, and gutta percha entering into multiple apical portals of exit. We've spoken a lot about the importance of 3-dimensional cleaning, shaping, and obturation, but let's not forget the rest of the seal. Restorations should be placed to protect the clinical crown and to prevent microleakage. Cases should be followed longitudinally to ascertain the status of the health of our patients. There's enormous potential in the field of endodontic diagnosis. Let's look at some information that I think you'll find most exciting. If you have 1,000 active patients in your practice, and assuming that each patient only had 20 teeth, then it could be said that you're the custodian of 20,000 teeth. If you missed endodontic diagnosis just 1% of the time, that would represent 200 teeth that haven't got the proper treatment. If we assume that all endodontics cost $500 per tooth, then you could see that your additional income would be $100,000. You can look at the rest of the information and begin to appreciate how staggering these numbers are if we did a complete diagnostic scheme. There's an old expression that there's a pot of gold at the end of the rainbow, and my assertion is that there's a pot of gold and it's within the teeth that visit you daily. As professionals, it's critical that we listen to the patient's chief complaint. We want to find out what makes their tooth hurt, how long it's been hurting, and when it has been hurting, to what extent they would rate the pain. It's important to listen carefully and record all this information. Endodontic diagnostic procedures may be divided into 3 parts: clinical findings, vital pulp testing, and the radiographic exam. A full mouth endodontic examination starts by retracting the lips and taking a good look into the vestibule. By retracting the lips, we can begin to see all aspects of the soft tissue. A mouth mirror is very helpful to look for caries, existing